Hi, everyone. Good morning or afternoon, depending where you're joining from. I'm Monik Mossini, a licensed mental health counselor based in Florida. Thank you for being here today. I'm going to talk about maximizing treatment effectiveness, specifically how integrating cognitive behavioral therapy, CBT, and dialectical behavioral therapy, DBT, can lead to more flexible, personalized, and effective mental health care. My goal isn't to say one approach is better than the other. In fact, both are already strong on their own. But when we thoughtfully combine them, we can do even more for our clients. Mental health care is changing. We're seeing more openness to therapy, more people seeking treatment, and more awareness of emotional well being. At the same time, the cases therapists are seeing are often more complex: trauma, comorbid diagnoses, emotional dysregulation, and chronic stress. So we need approaches that are not only evidence-based, but also flexible and adaptable. CBT and DBT are two of the most respected frameworks out there, but we don't always talk enough about how they can work together. So let's start with CBT. Aaron Beck developed CBT in the 1960s as a structured short-term therapy focused on identifying and changing unhelpful thought patterns. So the core idea is this: our thoughts, emotions, and behaviors are connected. If we can change the way we think, we can influence how we feel and how we act. For example, if a client believes, I always fail, they may feel hopeless and avoid challenges. CBT helps them identify the belief, examine the evidence, and replace it with something more balanced, like sometimes I struggle, but I've also succeeded. So CBT is highly practical. It includes identifying negative thought patterns, what we call automatic thoughts, and working to challenge and replace them. We also use behavior strategies like behavior activation to help clients take meaningful actions even when motivation is low. CBT is structured. Sessions have goals, homework, and a clear focus. Clients learn specific skills they can apply outside of therapy, which is one of the reasons it's so effective across a wide range of diagnoses, from depression and anxiety to OCD and PTSD. Now let's talk about DBT, Dialectical Behavioral Therapy. Marsha Linehan developed DBT in the late 1970s to address a specific clinical need: people who were suicidal, highly emotionally reactive, and not benefiting from traditional CBT. So she took the core elements of CBT and added something crucial: mindfulness and acceptance. DBT helps clients balance two opposite ideas: acceptance and change. For example, I'm doing the best I can be true, and so can I need to do better. DBT teaches people to hold both ideas at the same time. DBT is organized around four main skill areas: mindfulness, being present, aware, and non judgmental; distress tolerance, handling crisis moments without making things worse, emotion regulation, understanding and managing intense emotions, interpersonal effectiveness, navigating relationships with boundaries and assertiveness. These skills are often taught in group settings, while individual therapy focuses on applying them to real life situations. So, DBT is especially helpful for people who feel overwhelmed by their emotions and who might struggle with traditional CBT's focus on logic and cognition. So, how do CBT and DBT compare? CBT focuses on identifying and challenging thoughts. DBT focuses more on emotions, validating them, managing them, and accepting what can be changed. CBT encourages change through logic and structure. DBT says, yes, but let's also accept where you are. So in practice, that means CBT might say, let's challenge the thought, while DBT might say, let's notice the thought without judgment. Both are structured, skills-based, and supported by research, but they each come from slightly different angles, which is exactly why combining them can be so powerful. When we integrate CBT and DBT, we get the best of both worlds. CBT gives us tools to help clients think more clearly and act more effectively. DBT gives us tools to help them stay grounded, tolerate discomfort, and accept what they can control. And this matters because most clients don't just struggle with thoughts or emotions, they struggle with both. By combining these approaches, we create a more comprehensive system. We can help someone reframe a negative thought and stay present with the emotion that comes with that. We can teach skills for managing anxiety and tolerating distress when those skills don't work instantly. There are several benefits to this integrated model. It's more flexible. We're not limited to one set of tools. It's more personalized. We can tailor the approach based on each client's needs. It increases engagement. Some clients respond better to the mindfulness and emotional focus of DBT, others to the structure of CBT, and many to a blend. It builds a stronger skill set. Clients don't just learn to think differently, they learn to feel differently, relate differently, and cope more effectively. This can lead to more lasting, meaningful change, especially in complex or treatment resistant cases. Integrated CBT, DBT is especially useful in treating mood disorders, anxiety disorders, and emotional dysregulation. Think of a client with major depression and frequent emotional outbursts. CBT can help with the depressive thinking patterns, but DBT might be what helps them manage the intensity of their emotions. Or someone with social anxiety and borderline traits. CBT helps with thought distortions about social situations, while DBT strengthens their interpersonal boundaries and emotional resilience. So instead of forcing clients into one model, we meet them where they are. Research is starting to reflect this. Multiple studies show that combining CBT and DBT strategies can improve outcomes in areas like self-harm, anxiety, depression, and treatment adherence. For example, trials with adolescents have shown that integrating DBT's emotion regulation skills into CBT protocols can lead to better engagement and fewer dropouts. We still need more studies, especially in diverse populations, but the trend is promising. That said, integration isn't automatic. It comes with challenges. Therapists need to be trained in both approaches or at least understand enough of the other model to use it responsibly. We have to avoid overwhelming the client or creating redundancy. Just because we have more tools doesn't mean we need to use them all at once. Treatment needs to remain clear, intentional, and client-centered. Integration doesn't mean blending everything into a blur. It means using the right tool at the right time. So how do we do this in practice? First, we need education, workshops, supervision, and training that give clinicians real competence in both models. Second, we design treatment plans that combine techniques. For example, starting with distress tolerance skills from DBT to stabilize a client, then shifting to cognitive restructuring from CBT. And third, we stay flexible. Therapy isn't one size fits all. We monitor what's working and adjust as we go. So integration is a mindset as much as a method, a commitment to using what works in the way that works best for the person in front of us. So to wrap up, CBT and DBT are both excellent therapies. They've helped millions of people, but we don't have to treat them as either or. By integrating them thoughtfully, intentionally, we can meet clients more fully, treat more complex presentations, and offer more comprehensive care. As the field continues to evolve, I believe this kind of integration will become more standard and probably more necessary. Here are my references.
Okay, thank
you so
you.
much for listening. Yes, I'm happy to take any questions or hear your thoughts.